is acute decompensated heart failure, different from de novo heart failure. Now, what is very important is to understand what is the difference between de novo heart failure and acute decompensated chronic heart failure. So, acute decompensated heart failure, the patient is generally old. He has a known history of having breathlessness, swelling, and other symptoms of underlying heart failure for a long time. And if one takes a history, he will have ischemic heart disease, he may have arrhythmia like atrial fibrillation, he may have associated diabetes, stroke, he would have had some history of bypass, angioplasty, he may have comorbidities like COPD. Whereas in a person who is presented for the first time, de novo heart failure, is less likely to get all these history. So history of chronic illness may be there, but the probability is less. And one might get the signs of disease which has not been recognized before. Now, the patient is usually will give a past history of having been healthy, of being able to do all his duties or her duties fully. Now, the trigger events. The trigger events for acute decompensated heart failure are usually, one may be non-compliance, maybe poor loss to follow-up, maybe underlying infection, maybe pregnancy, which is a strain on the, or a cardiovascular challenge for the weak heart, or excessive salt intake. So these kind of precipitating factors or excessive alcohol abuse. So these sort of history will be there, which will give a reason of fluid overload. So these sort of trigger event will be there very commonly in decompensated chronic heart failure. Now, what will be the trigger events for de novo heart failure? There is a sudden event. For example, there is some arrhythmia, or there is a cardiac ischemia, which may be leading to some valve failure. There may be a myocardial infarction. There may be an infection causing inflammation of the heart, like viral myocarditis, or some drug toxicity. The clinical presentation in de novo heart failure, because it is presenting for the first time, one can expect very precipitous fall. The patient may be going into straightway into pulmonary edema or cardiogenic shock, and the course of the disease can be very stormy and worsen very rapidly. So these are people, we have to be very energetic and straightway get them admitted in the hospital. Whereas the acute decompensated chronic heart failure will come with possibly history of steadily worsening dyspnea, progressing to orthopnea, swelling of the feet with progressive lower limb edema, swelling of the abdomen due to ascites and weight gain. So these are people who are amenable to, even if they require admission, they may not be getting admitted to the ICU, or they will require bed rest. And if the patient is compliant with close OPD follow-up and cautious, increase in diuretics and looking for precipitating factors like tachycardia, tachyarrhythmia, anemia, infection, we can control them even either in an ambulatory state like at home, or with some rest at home, or with an admission to a low dependency unit. So we can manage them without ICU care. Now, what is the main pathophysiology of decompensated heart failure? So it is either there is fluid overload, the heart is weak, so there is LV dysfunction causing pulmonary and systemic vascular congestion, and with neurohumoral activation. So this is what is causing the heart failure. And these are the factors we go about reversing. Whereas in de novo heart failure, we have to look, why is the myocardium not able to function? Is it ischemia? Is it inflammation? Is there an acute valve deficiency, like acute mitral regurgitation? Or is it a arrhythmia? For example, atrial fibrillation with fast ventricular rate, a ventricular arrhythmia. So we have to look for what is the illness which has caused this heart to suddenly decompensate.